Good morning, everyone. Welcome to our webinar this morning. We are very delighted to actually feature a family genetics thinking about preparation for Family History Month with October, November being the time frame that we launch into holiday season. And we really think about the making the most of the opportunities with family members to gather information about history for health and specifically thinking about colorectal cancer. So thank you. We're ready to go ahead and begin this morning. So we are delighted to have two very wonderful presenters, Lisa Axel and Lisa Koo. So they were our two genetic counselors from the University of Colorado, and I'm actually sharing our slides now here this morning. Okay, great. So we're going to go ahead and get started this morning with information about family history. I do want to start by providing a little bit of information about Fight Colorectal Cancer and our team in terms of the work that we're doing in terms of the different resources that we have available, and then even after the webinar, just some information that we'll be asking about how you enjoyed today's topics, maybe even suggestions for future presentations, and of course we'll provide some good resources for all of you to actually collect information. So a little bit about our speakers. Lisa Koo and Lisa Axel are both genetic counselors working here at the University of Colorado Cancer Center. Have had a lot of experience even working at the national level and specifically do a lot of work with Dr. Dennis Onen and our team at the Hereditary Cancer Center. So we're very excited to have them. And just a quick reminder that everyone that we have archived webinars and previous presentations that are on our website, and today will be archived as well for anyone who wishes to share this information with friends or family members. I'd also just like to remember everyone that one of our seminal products in terms of the Guide in the Fight, looking at late stage, is still available on our website. It's meant to be as a resource, as a guiding tool for those who are going with stage 3 and 4 colorectal cancer, thinking about real-time treatment issues as well as long-term and latent side effects, and has been a fantastic guide. We will be updating the guide soon, and then also are in development of stage 2 guide, but we're really excited about this tool and hope that you'll all be able to utilize this going forward in your journey and sharing this with, again, friends and family members or even within your medical institution or site. The guide is actually available and able for download on the Fight CRC website, and again, available online at the address below, or just by Googling Fight Colorectal Cancer. You'll be able to have access and resources and information for these resources. Just a quick note as well is that we actually will be providing more information, or actually we are really interested in the research side and looking at innovative means for colorectal cancer. Hold on just a minute. In terms of colorectal cancer research, and our Lisa Fund is one of the means by which we do that by donation to our site in terms of thinking about research and donation. 100% of the funds actually go to late-stage CRC research, and especially in terms of innovation and giving scientists the opportunity to really branch forward in the areas that really need the most exploration that other groups such as NCI and CDC might not be able to fund initially. So we're really excited about the research in the Lisa Fund, and just ask that for donations or any information to contact us as we move forward in this initiative. The other just quick note of mention is that Fight CRC really is excited about bringing information and resources available for survivors, for post-survivors, family members. But again, this is in no means to replace the direct medical care services, and that of course if there's ever any sort of emergent situation, 911 or a direct connection with a medical provider is very important. And as I mentioned, our two speakers today, Lisa and Lisa, will be joining us. We're very excited to have both of them here joining us, and we actually have the opportunity, as we're all in Colorado, to be in the same office. So here's the lovely pictures that they were very excited to provide for all of you. But we're really excited because I think they both bring a lot of fantastic clinical as well as education to the work. So as a quick reminder as well is that in the control panel of your presentation, there is actually an opportunity in the chat to type messages and questions. We encourage everyone to provide information or questions, any sort of feedback. We will entertain those questions at the close of the webinar. And I also just want to remind everybody today is that we're really going to be featuring and focusing on familial and hereditary syndromes and thinking about what information to collect from family during the course of the year, maybe even making, again, the most of the opportunity. We're hoping that this opportunity will build upon information that you all might collect. We're going to reconvene in January, and at that time, Lisa and Lisa will actually then talking about some of the more prolific inherited and genetic syndromes that might have actually come up in terms of the information that you've collected, really focusing on CRC. So again, we're really hoping that we can take the time, the information, that you'll utilize that when the time that you have with friends and family members to really collect information that might give your family the best idea of what to do to actually protect health and to what actions to take going further. And in January, spending that time to talk about some of the, some of the syndromes and the like that might actually be most relevant to colorectal cancer. Between now and then, though, we also encourage you that if you have questions, that you get a hold of us through Facebook, through after our presentation today, and then we'll be even posting blogs and information about where to find resources and what information to collect. That you get in touch and get involved through our resource line, or either through any of our multiple channels to ask questions about what you've learned here today, and we'll try our very best to ensure that you have resources with that follow-up then in January. So with that, I actually would like to take a moment, if we can, and Michael, if we can look at utilizing the polls, that would be fantastic. So we have a couple of specific questions that we'd actually like to be able to ask prior to our webinar, but actually I'm not sure at this time if we're able to do that. So we will actually just go ahead and go into our presentation, and at the close of the webinar, actually we'll go ahead and spend that time just to make the most of the opportunity this morning. Okay, so Lisa Koo and Lisa Naxel, and we will go ahead and go forward with our presentation this morning. Okay. Thank you, Andy. This is Lisa Naxel, and just took us a couple seconds there to move around in the office. So not everybody knows what a genetic counselor does, and so I thought I'd just take a minute to tell you a little bit about our jobs. One can think of us as a genetic educator or translator who takes complicated genetic information and turns it into meaningful information for individuals and their families. We do cancer risk assessment for individuals with a personal and or family history of cancer, and we help them understand their risks for cancer, what the likelihood might be of an inherited component to the family history, and how this may change medical management for them and their family. So today we're specifically going to talk about genetics, family history, and colorectal cancer. So we've had some debate here, and it looks like either October or November is National Family History Month. So this is very timely regardless of whether it's October or November. But with the holidays coming up and with a lot of individuals getting together with family, this is a good opportunity to think about questions that you may have for family members that you might be visiting with. So when we think about common diseases here in the United States, like cancer or heart disease, diabetes, hypertension, etc., a lot of these have some of the same risk factors. Some of these are ones that we have some control over and are things that we hear about over and over again in terms of lifestyle and diet and alcohol and smoking cessation, and we all try to work at these
to our best degrees of success. But then these other factors, the ones that we really don't have much control over in terms of age or family history. And so today we're going to focus on how family history factors into cancer risk. So when we think of cancer, we know that there are multiple features that contribute to cancer risk, like lifestyle, our genes, environment, and when we think about environment, it's not always necessarily our external environment, but also our internal environment, but then specifically family history. So family history can help us identify individuals who have risks for cancer that exceed those of the general risks that we all have based on lifestyle and the health choices that we make. It can help us identify individuals who are at an increased risk for cancer so that they may benefit from increased screening or possibly other preventive options. And this is where family history and possibly genetic testing play a role in healthcare. So when we think of individuals with a cancer history, we divide families into three broad groups based on what we're seeing in the family history. So the vast majority fall into the sporadic category, but then there's some familial component and then some that fall into a more strongly inherited component. Now this pie chart is specifically for colorectal cancer, but a pie chart like this could be used for most other types of cancers as well. So for example, breast cancer or pancreatic cancer or most other types of cancers. So it's important to remember that the vast majority of cancer is sporadic in nature, but that there is a very small but important portion of families who might have an inherited component to their cancers. And it's important to identify these individuals because medical management might be different. So we're going to use Karl here to illustrate how information about health history of family members can change our impression of cancer risk in a family. So our goal is to highlight questions that can help you get the best information about your family history of cancer. And so we're going to use Karl to show the difference between sporadic, familial, and inherited cancers. And we're also going to describe how this changes medical management. So Karl here is 62 and was just diagnosed with colon cancer. And his doctors ask him if he has any family history of colon cancer, to which he responds that he doesn't think there's any family history, but also he doesn't know that much about his family history. So this certainly sounds like sporadic cancer. No one else in the family with a colon cancer. And we use family trees a lot of times to look at patterns of cancer in a family. And so I was going to spend just a minute to orient you to these family trees because we're going to use these to describe the different patterns in terms of sporadic, familial, and inherited patterns. So squares are men and circles are women. If there's a line connecting two people, it means that they have children together. If there is a line above like this, this means that this is a sibship or siblings. And then, so this would represent Karl's two sisters, his parents. Here are his children. And then here are his relatives on his mother's side of the family. And then his relatives on his father's side of the family. So here are the grandparents in this generation. And then aunts and uncles in this generation. So we were saying that this pattern that we're seeing in this family tree here looks like a sporadic pattern. And that's because we're seeing a later onset. So 60 and older for colon cancer is more in the general population risk. There's no clear pattern of cancer, so there aren't multiple individuals on one side of the family who have had a history of cancer. And we wouldn't expect that there would be any kind of inherited gene mutation explaining this family history. And family members, like Karl's sisters, would have a small, if any, increased risk in cancer based on this family history. So why is this important? This is important because depending on family history, it might change medical management recommendations. So in a situation where there's a sporadic pattern, we think of the risk as being that of the average individual, and we would recommend general population screening guidelines. But as often happens when someone has a cancer diagnosis, we often learn more about our family history of cancer. So Karl, upon his diagnosis, actually learned that his father's death certificate showed that he had colon cancer at the time of his death, at the age of 80. So it wasn't the cause of his death, but it was something that they found at the time of his death. And also, following Karl's diagnosis, his sister had a colonoscopy, and 3 polyps were found. So now this appears to be more of a familial pattern of colon cancer in the family. So here we're going back to that same family tree, but here we're seeing Karl as well as his father, who both had colon cancer, both in that older category, and then his sister with those colonic polyps. So in someone who maybe falls into more of a familial pattern, we might see a clustering of cancer in the family, but maybe no clear patterns. Maybe it's not, we're not seeing it in every generation, or the individuals with cancer maybe aren't directly related to one another. Typically, in more of a familial pattern, the cancers might be later in life. And these may very well be due to possibly unknown inherited genes that maybe are what we call less penetrant or have less of a cancer risk associated with them. It could also be due to shared environment or possibly a combination of the two. But most of the time, genetic testing is not informative or useful in families with more of a familial pattern. So again, in someone who falls into more of a familial pattern, we would say that cancer risk is moderate and that there would be personalized screening recommendations based on this information. So the NCCN guidelines recommend that someone who has 2 first-degree relatives with colon cancer would have colonoscopy every 3 to 5 years, and starting younger than the general population guidelines, which is to start at 50 and to do colonoscopy every 10 years. So someone who has more of a familial pattern, they have different screening recommendations than would be recommended for someone who falls into the sporadic category. So again, just highlighting how family history can change medical management. So this would affect medical management for Karl's siblings, as they now have both a father and a brother who've been diagnosed with colon cancer. So we mentioned that Karl's sister had a number of colonic polyps. One of the things that we are going to be emphasizing during this talk is that sometimes pathology reports can be invaluable. And so knowing the different types of polyps and number of polyps can help medical professionals determine if maybe some of the cancers in the family could be due to one of the rare inherited cancer syndromes. So when we see adenomas, these are the precancerous types of polyps that are not uncommon in the general population, but typically individuals don't have lots of these polyps. If we see lots of these polyps, it can make us think about a very rare inherited cancer syndrome called familial adenomatous polyposis. In Lynch syndrome, that we'll be talking a bit more about in a little bit, we also see these types of adenomas. There are other types of polyps as well, like hyperplastic or hamartomatous or juvenile. If we are seeing these types of polyps on a pathology report, it would lead us in an entirely different direction in terms of thinking about what may be the possible cause of the cancers in the family. Also, the number of polyps can be very important. So if we're seeing 10 or more cumulative polyps over an individual's lifetime, if they are of the adenomatous or are adenomas, this can, again, lead us to investigate the family history more for possibly one of those polyposis syndromes. So pathology can be very important in terms of understanding what the polyps were and the number of polyps that were found. So as we continue with Karl, again, he delves further into his family history, and he learns that actually his maternal grandmother had some type of gynecologic cancer at a very young age, and therefore Karl's mother had a hysterectomy, removal of the uterus, at a young age for prevention. I would say that in my experience that the type of cancer that I would say that there is the most confusion on or about when individuals are gathering family history information is specifically the gynecologic cancers. So when we think of gynecologic cancers, there's three main types. We have ovarian cancer, uterine cancer, and cervical cancer. And depending on which type of gynecologic cancer we're seeing in the family, it can give us very different clues about whether or not there may be an inherited component linking cancers in the family. So specifically, if we were to see uterine and colon cancer in a family, that can make us think about Lynch syndrome. Or there's another inherited syndrome where we can also see that combination that's called Cowden syndrome. We see different types of polyps in that syndrome. And we'll be talking more about these different syndromes in January. If we see ovarian cancer and colon cancer, that could make us think about Lynch syndrome. But if it's cervical and colon cancer, that typically wouldn't lead us to think about Lynch syndrome. Cervical cancer is most often related to the human papillomavirus and is rarely due to any type of inherited predisposition. And then if we see breast and ovarian cancer, for example, it would make us think about hereditary breast and ovarian cancer syndrome. So learning, again, this can be another opportunity to look at those pathology reports, or maybe even asking family members, how is the cancer diagnosed? Was it on a Pap test? Was there heavy bleeding, bloating? These can all be useful questions that can possibly help us determine what type of gynecologic cancer it was. And since it is important because it leads us down different paths, this can be an important question to ask. And also important to know that not all individuals have hysterectomies due to an actual cancer diagnosis. Sometimes there may be cysts or other benign growths that lead to an individual having a hysterectomy. So because of the very young gynecologic cancer, there's now more of a suspicion that maybe this actually represents an inherited component. So we're specifically thinking about the cancers that we see linked here on the mother's side of the family, and that maybe Karl's father's cancer was a red herring and would more represent age-related sporadic colon cancer. So seeing young cancer, Karl's mother, she's essentially, having had a hysterectomy, we have less of an opportunity to know if she may have developed a cancer, if she had not chosen to have a preventive procedure. And then we're seeing two siblings here who've both had colonic findings. So what are features that we look for in families that make us suspect that there is an inherited pattern? So we look to see if there are young cancers in the family, so colon cancer diagnosed before the age of 50 or uterine cancer diagnosed before the age of 50. We look to see if there are multiple generations on the same side of the family with either the same type or related types of cancers. And Lisa's going to be sharing with you more about cancers that we can see related to colon cancer specifically and Lynch syndrome. And we also look to see if there's anyone in the family who has had cancer more than once. So two primary cancers, not a metastasis, but actual different cancers, or someone possibly who's had two related types of cancers. So again, screening is very different for someone who falls into the inherited risk category. In this group, we would say that the cancer risks are really quite high, and Lisa's going to share that in more detail. And these individuals may be recommended to have a genetic evaluation or possibly genetic testing. And there are very specific guidelines with screening recommendation and other risk reduction recommendations that they may consider. We also know, going back again to pathology reports, we also know that there are a lot of institutions around the country that do testing of tumors, specifically of colon and uterine tumors, that can serve as a screening test for Lynch syndrome. So the pathology looks at the colon cancer or at the uterine cancer and then does some staining and some other analysis that can help determine if there is a possibility of Lynch syndrome, or it can also help rule out Lynch syndrome. But it's very important to remember that these pathology tests are screening tests and they are not diagnostic. So a finding on one of these tests does not indicate a diagnosis of Lynch syndrome, but it does result in the recommendation for a follow-up next step potentially. So Karl's tumor did have this type of testing and did show by the screening test that there is a possibility of Lynch syndrome, and therefore he would be recommended to do further genetic testing to potentially determine whether or not his colon cancer and the cancer pattern that we're seeing in the family is due to Lynch syndrome. And I am now going to turn it over to Lisa Koo.
Okay, so Lisa has just gone over a great example of how knowing your family history better will change what the cancer risks are for you and your family. Karl went from a sporadic case of colon cancer to a potential hereditary cancer syndrome. So now the question is, why is knowing if my family has a hereditary cancer syndrome helpful? So let's continue with the cancer syndrome that we're suspecting in Karl so we can exemplify what this changes. So Lynch syndrome is the most common type of hereditary colon cancer, with colon cancer risks upwards of about 80%. But colon cancer is not the only cancer that we see with Lynch syndrome. We also see endometrial and stomach and biliary tract and ovarian and urinary tract cancers. So now, instead of just talking about risks and screening for colon cancer, we also need to think about risks for these other types of cancers. And in addition to these cancers, sometimes we even see brain cancers or skin lesions called sebaceous gland tumors, which are specific to certain subtypes of Lynch syndrome. And on top of that, we're always learning more about these hereditary cancer syndromes, and more recently we're finding families with Lynch syndrome and a possible increased risk for also pancreatic, prostate, and breast cancer. These cancers are not currently listed as part of the diagnostic group of Lynch-associated cancers, but we're definitely seeing a pattern of some sort which includes these cancers within Lynch syndrome families. So what changes with cancer screening if a person is identified to have a hereditary cancer syndrome like Lynch syndrome? So based on the cancer risks we know that are increased, we would include the following. We, of course, would talk about colonoscopy, but unlike the screening guidelines that Lisa was discussing for Karl's family when there was a familial risk, which was that every 3 to 5 years beginning at age 40, individuals with Lynch syndrome begin screening around age 25, and we screen every 1 to 2 years. Also, we might consider adding other screenings, such as upper endoscopy for stomach cancer, although the recommendations for this are somewhat controversial and actually might be highly dependent on if there's the presence of stomach cancer within a family history. Some other screening, urine cytology, kidney imaging, and screening of the uterus and ovaries would also be considered. So all of these are not part of standard screening guidelines for the general population. So you can see how the screening recommendations sometimes go beyond what's recommended just based on family history when a hereditary cancer syndrome is identified. From a preventative standpoint, surgical options might include removal of the colon or parts of the colon and removal of the uterus and ovaries depending on an individual's circumstances. Medications could be considered for some people. These sometimes reduce polyp formation, but this also needs to be discussed more in depth with a physician because we need to make sure that this is an appropriate option based on other risk factors and, again, based on family history. And as both Andy and Lisa have said, we're giving a pretty general overview about Lynch syndrome today, but in January we'll go into much greater detail about the specifics of this syndrome as well as some of the other hereditary colon cancer syndromes. So if you're interested in learning more about these hereditary cancer syndromes, we'll hope you join us at that time. Okay, so shifting gears just a little bit, since we're talking about family history and hereditary cancer syndromes, we also feel it's important to address the genetic aspect of cancer as well. So all cancer is genetic, but only a small portion is inherited. And to better understand this, I'm going to give you a basic genetic lesson. So our body is made up of trillions of cells, and inside the center of each cell is our genetic information. So if you were to scratch off a skin cell or look at a hair cell or even a colon cell, you would find the same set of genetic information. This information is packaged into these structures that we call chromosomes. And so each chromosome is made up of a bunch of tightly wound material called DNA. And DNA is the building blocks of our genetic code. And parts of the code are grouped together to make a set of instructions for the body to read. And these instructions are called genes. So each gene codes for a protein that then has a specific function in the body, and those proteins have many different functions, including things like making us how tall we are, what color eyes we have, or whether or not we're predisposed to cancer. So what is cancer? Well, cancer is essentially an overgrowth of abnormal cells. So at the time of birth, we start off with a certain set of cells, and then these cells make copies of themselves as we grow. And over time, we start to accumulate damage to some of our cells. This happens, as Lisa was talking about, because we're exposed to things like environmental influences, sometimes external, things like the sun, or other internal external factors. And what these do is they cause mistakes, or what we sometimes call mutations or alterations to our genetic code. The older that we get, the more of these mutations we accumulate. But our bodies have an amazing ability to either repair many of these mistakes or to tell the body to stop making copies of that damaged cell. In cancer, what happens is that a cell gets so many mutations that it loses its ability to fix the mistakes or even stop making copies of itself. And now it loses control and goes into overdrive. And this cell, in this overdrive, it accumulates all these abnormal cells, and this is what we call cancer. So this is why we say that all cancer is genetic, because what's happened is that there's an acquired damage to the genetic code in all of these cancer cells. Now, the cells in your body may never reach this point, but the longer that we live, the more likely this is to happen, which is why most sporadic types of cancer occur later in life. Now, with hereditary cancer, what happens is that you're born with already having a mutation present in every copy of your cells. So remember, this doesn't cause cancer, but it puts you one step ahead in the cancer process. So a person with an inherited genetic mutation, we expect to see cancer happening at a younger age, and maybe even more often. Again, this is why we ask the questions about age and number of cancers in a family history. So these hereditary mutations are inherited from the genes that are passed down from your parents. So this is a picture of a real set of genetic information, and these black and white zebra striped structures are actual chromosomes. So you can see that these chromosomes are labeled by size, numbered from largest to smallest, and the last set of are your sex chromosomes, which determine if you're male or female. So we have 2 copies of each chromosome because we inherit 1 copy from our mother and 1 copy from our father, which is why we say we have half of our traits from each side of the family. So since we have 2 copies of each chromosome, we basically have 2 copies of each gene. So the majority of hereditary cancer is inherited in what we call an autosomal dominant fashion, which means that you only have to have inherited 1 copy of a genetic mutation in order to be predisposed to cancer. And then any offspring of an individual with a mutation would have a 50% chance of inheriting that mutation. So here's an animated explanation of this inherited pattern. So the man on the left has 2 copies of a gene, and the circle with an X through it represents a genetic mutation in that gene. So he carries 1 gene with a mutation and 1 normal copy of a gene. And his partner has 2 copies of the normal gene. So when they have children, if the man passes on the copy of the gene with the mutation, and his partner passes on one of her genes, then that child is a carrier of the genetic mutation. And if this is a cancer-related gene, may be predisposed to a hereditary cancer condition. So if the man passes on the normal copy of the gene, and again his partner passes on one of her genes, then this child is not a carrier, and subsequently is not an increased risk for cancer above the general population. So this is where we get that 50% risk or 1 in 2 chance to pass on mutation. The same probability is true if the man passes on one or the other copy of his genes and his partner passes on the other normal copy that she carries. So still, as you can see, there's a 2 out of 4, or again, a 50% chance. So this is how knowing if there's a hereditary component to the cancer in a family can affect risk for family members. So for example, going back to Karl's situation, if a genetic mutation is identified in Karl, then he likely inherited from his father or mother, which means that his siblings would each have that 50% chance of carrying that mutation as well. So now what? So we've given you some information about how family history affects risk and how genes and inheritance work together with family history. Well, what now? Well, we invite you to think back to what you know about your family history of disease and identify the important aspects of your family history. So think about both sides of the family because, again, genes come from both your mother and your father. Try to think back at least 3 generations, so grandparents, aunts and uncles, and cousins, so we can see if there's any particular inheritance patterns. And also think about going the other way, so children and grandchildren are important too. Although most cancer syndromes, we typically don't see an onset of cancer under the age of 20, but that's not always true, especially in some of those polyposis syndromes, so the more information that you can gather, the better. Try and get specific diagnoses. As Lisa discussed, the difference between all the female organ cancers can make a difference in what cancer syndromes we might think about. Get the age of diagnosis. The younger the age of onset, the higher the likelihood of it being hereditary. And also, something that a lot of people don't think about is determining the number of family members without disease. If we see a family where an affected individual has just 1 sibling, we might view that family differently than one where there's an affected individual but that person has 13 unaffected siblings who don't have cancer. So the number of unaffected family members is still important in risk assessment. So when you are sitting around the dinner table at Thanksgiving or whenever your next family gathering is, here are some questions you could consider asking. Did anyone pass away at a younger than average age from cancer? So again, looking for people under the age of 50. What kind of cancer did they have? Again, trying to get specific diagnosis. Do the same cancers keep appearing in different family members? So looking for those clusters of cancers of the same type or more cancers than we would expect to see just by chance. And then write this information down. So we know that most information around a family gathering will come verbally, and by the time you get in to see your doctor, you may have forgotten the specifics. So it's really very helpful if you can write this information down. And talk about it with your children and grandchildren. So we find that it's very common for information not to be known about a family history just because people didn't talk about it. So maybe the conversation starts with you, and you ensure that the information gets passed down to the next generation. So some ideas on how to get those specific cancer diagnoses. Again, the best way is to get some written documentation. And some ways to do that, as Lisa was emphasizing, are things like pathology reports, really getting the details of those polyps or other the cancer types. If any genetic testing was done, finding out exactly what was tested for and what those results are. Any medical records or treatment notes, and even autopsy reports or death certificates, which often state the type of cancer that an individual had at the time of death. And this is actually especially important in cases where a family member may have been reported to have multiple types of cancer, such as colon and lung cancer. And it would be helpful to know if these are 2 separate primary cancers or if it's a spreading of one cancer to another organ, which is called a metastasis. So if you get all this information and you are suspicious of a hereditary cancer syndrome, or you simply have questions about your family history, then you can consider making an appointment with a genetic counselor or other cancer genetics professional. What we do is we sit down and we go over your family history in detail, and we provide a cancer risk assessment and evaluation. And then we provide information in the form of education and counseling and discuss psychosocial issues that might be specific to your individual situation. So we know that each individual and each family is different, and even if you have the same exact personal and family history as, say, someone like Karl, the impact of knowing this information might affect you and your family completely differently. So if appropriate, we can also help with coordinating ordering of genetic tests and discuss what options for testing are available. And this in particular has become extremely complicated in the past few years. And again, we'll go into much more detail at our next webinar when we talk about these specific cancer syndromes. And finally, we can also help with entry into clinical or research studies if needed. So on average, a meeting with a genetic counselor takes about an hour. So we get pretty in-depth with our discussion. So our take-home message for today is to take advantage of these potential upcoming family gatherings and find out as much as you can about your family history. And then take this information along with your own personal history of risk factors for cancer, so things like your diet, exercise, or lifestyle, and then talk with your doctor about all these things together so you can come up with a plan for the most appropriate screening and cancer prevention options that make sense for you and your family. And with that, we thank you for your time today, and we'll now take any questions that you might have.
Great. Thank you, Lisa and Lisa. This has been fantastic information in terms of about information to collect and how we go about this in the background. One specific question that I think comes up is that particularly for the sporadic cancers, and that this subset, that at this time there might not necessarily be any sort of specific background information, or actually I should say just information about what is the causation of cancer, and then with the growing field of genetic counseling, genetic testing, if someone has a cancer diagnosis that isn't necessarily genetic or familial linked or syndrome based, but actually there's advancement in science and with even sequencing or the like, what is your advice to folks that even see information that think that there may or may not be a family history, but they just can't quite link it at this time? Is there a frequency in which you think about maybe revisit, you know, with where, you know, genetic testing and counseling is going? Any specific recommendations for folks in this sort of situation? And I will tell you that there's a lot of good brain power happening right now with all of us in the room.
This is Lisa. I would say that there is still a lot of development and still a lot of research going into genetics and colon cancer. There is new technology currently called next generation sequencing that is allowing us to look at many more genes than we potentially did in the past. But most of the genes that are included on these panels are ones that are specifically related to these pretty well described and pretty well known syndromes. I think many of those more moderate genes, or genes that might explain those familial families, or maybe even possibly some of those sporadic cancers, are still at this point in time not included on some of those genetic tests. And I would absolutely say that that is information that is continually being investigated, and I think there will be more potential for that type of genetic testing potentially in the future.
So this is Lisa, and I would add to that as I was saying about how all cancer is genetic, there's a lot of work being done looking at the genetics of specific tumors and then translating that information into treatment. And so looking even at what we would consider sporadic cases, there still might be potential for looking at the tumor tissue and testing for genetic changes that might alter treatment. And so we can still use genetics in that direction as well.
And I would also add that currently, most of the time we can't answer why a cancer occurred. So maybe 5 probably about 5% of colon cancer. Genetic testing, and that would be on the high end, genetic testing may give us an answer for why that colon cancer developed. But that means that 90–95% of the time, genetic testing does not show a genetic change, and we can't answer that question of why that colon cancer occurred.
Okay, great, thank you. The next question that we have was a little bit about process in terms of thinking about coverage, insurance coverage. If someone does think that there's a specific need to connect with a genetic counselor, maybe in genetic testing, I don't know if either of you could just talk a little bit about what is that process, maybe what to check ahead with insurance, how to connect with resources, and just maybe talk a little bit about, even if you don't mind, information about even at state level, maybe if there's specific websites to even think about for connection or anything, but just sort of a process level, how does this work if you really want to connect to find out more?
I would say that most insurances cover genetic counseling in my experience. There is a national group of the National Society of Genetic Counselors, and they have a website that is National Society Genetic Counselors, so nsgc.org, where you can search for genetic counselors based on geographical area as well as based on specialty. So genetic counselors can work in many different fields, and so specifically finding someone that has experience in cancer genetics can be very beneficial. I think something that is always important to remember is that genetic testing, if a family chooses and wants to proceed with genetic testing is most informative if someone in the family who has had a cancer diagnosis that we're worried is part of an inherited syndrome has that genetic testing first. So we always try to encourage individuals to talk to their family members who've had cancer to see if either genetic testing has already been done or if that person would be willing to do the genetic testing first. And the reason for that is going back to that there's so much we don't know about genetics in cancer that if we expect that we're going to find a genetic mutation in a family, we would expect to find it in an individual who has had the type of cancer that we're worried about. And then following that, then if a mutation is found, then family members could have much more of a definitive test, like Lisa was sharing, and figure out whether or not they inherited that mutation, in which case it would result in medical management changes. But also on the flip side, if we know what caused the cancer in the family and someone does not have that mutation, then we can be much more reassuring in terms of cancer risk. But if someone who has not had cancer, has genetic testing, and is negative, does not have a mutation, because there's so much we don't know about genetics and cancer, we don't know that we were testing for the right gene. So it's often less informative to test someone without a cancer diagnosis for the family as a whole.
So just also to address a little bit more about the insurance coverage. So much of what we do when we're meeting with an individual or family is that we're going over the family to see what, if any, hereditary cancer syndromes are appropriate to be tested for. And many of these insurance companies actually have their own clinical criteria that have to be met before coverage can be seen. And so part of our process when we do the risk assessment is to determine whether or not your family meets those criteria and what, if any, testing would be appropriate. And then we can from there let you know if we think that your particular insurance is going to cover that test or not. But it's gotten, as I alluded to, it's gotten very complicated, and so it's a harder question to answer in just a few minutes at this point.
I guess Lisa and Lisa, as we're waiting, I just actually wanted, or I'll actually ask another question and then just make a quick comment. In terms of the clinical side, and I know that even in the presentation, you got a lot of sort of notes around, you typically get a lot of common questions from folks. Other than the ones posed, I would have you just take a minute to think about, other information that might be confusing or that might be common questions that come up. But while we're thinking about that, I just wanted to remind everyone that part of what we ask is that in terms of the presentation, and that we do entertain the general questions and information pertinent. If you do have specific medical advice about treatment, about surgery, about radiation, about side effects, we do have the Guide in the Fight, and the materials that are listed and resources are a fantastic resource. However, Fight Colorectal Cancer and many advocacy groups are not able at this time to provide direct medical advice, and it's very, very important that you connect with a medical provider. But again, we do have the resources available through Guide in the Fight. We do have a resource line that we can try to help connect you with other folks that might be able to help that. But again, we're really not in a position to provide direct medical advice or to replace the insight of a provider or medical team. So my quick question back to you two ladies, that in terms of some general questions that you get in clinic or that might just be very pertinent to the information today.
So one question that might come to mind in relation to family history is a lot of times we see families that don't have a very strong relationship with their family members and are not quite sure how to go about approaching them or asking them for more information from a medical standpoint. And we're finding that in this day and age with social media, it's been very interesting how many people have actually been able to identify family members through resources like Facebook or whatnot, where it's a little bit of a feeling of, okay, it's safe to reach out to these individuals and ask them a general question about their health without delving too deeply into their personal life. But it has worked for some families, and so that might be an avenue that you could consider trying to reach out to some of those families just to ask the general question of what your medical health is, or do you remember what your father died from, those kinds of questions.
That's excellent. Thank you, Lisa. That's exactly, I think, maybe not always the most obvious type of situation, but definitely in that situation, definitely good advice. Lisa?
And I would just, I guess, add, this isn't so much a question, but just a comment, that unfortunately cancer is pretty common. And so a lot of the times we'll have individuals that come in and will specifically say, I feel like there's so much cancer in my family. And but again, getting specifics about the age of diagnosis and the type of diagnosis is very valuable. Just having a history of cancer in your family does not necessarily mean that there's a strong inherited risk or that your risks are necessarily about of the general population. So there are those specific questions that really help us determine our level of suspicion of there being an inherited component.
Okay. Wonderful. I actually received one question in terms of not maybe directly to colorectal cancer, but one of the questions is specifically around mental health and Alzheimer's and any sort of connection with familial or genetic syndromes, which I did want to just quickly ask and entertain that question. If you all could just answer anything specific.
So yes, the world of genetics is expanding rapidly, and there are definitely areas where the focus of looking at family history of some of these other conditions is becoming much more prevalent. So definitely there are groups that are looking at genes associated with Alzheimer's and other conditions that you could explore. The website that Lisa mentioned, the National Society of Genetic Counselors, also lists all genetic counselors nationwide and all their different specialties. So you could certainly try a place like that. Here at the University of Colorado, we actually have a separate adult genetics clinic where they look at all those different types of conditions except cancer. And so we focus specifically on hereditary cancer syndromes, and they can address a little better some of those other questions.
And I think it is true that for those common conditions like Alzheimer's or dementia, or that just like cancer, the vast majority probably fall into that sporadic category, and that a very small subset has a strong inherited component as the explanation. There's one of these very rare inherited colon cancer syndromes, Cowden syndrome, where occasionally we can see some developmental delays and so forth, and that is one of the polyposis syndromes. But other than that, I'm not aware of there being any link between colon cancer and other mental illness.
Great, thank you. There's a really good question that just came through about family members that might have died from cancer, or any, or actually just deceased in general, and then ultimately, in terms of what information that people might be able to get about their specific genetic conditions, or even how you might go about finding this information for folks who are deceased or family members who want to learn more about their health, but the person may no longer be living. So I don't know if either of you can speak to that.
So I addressed that a little bit in terms of trying to find those medical records. So most hospitals will keep medical records for an extremely long time, so that's always a good place to start if you know where that person was treated or diagnosed. And the death certificates are public information, so you can go to the state registry and pull up a death certificate, and oftentimes they will state on there what type of cancer an individual had at the time of death. So again, trying to get some written type of information would be the most useful to try and get the most accurate diagnosis if other family members are not sure, not aware of whether or not there's anything. And so, typically what they're looking for, name, full name, date of birth, and date of death if you have it. And there's sometimes a small fee that you'll have to pay to obtain that death certificate. But it's available out there if you know exactly where they died or what state they died in.
Wonderful, thank you. And then there was another comment that came through related to, that we've talked a lot about syndromes related to a specific cancer diagnosis, and I know Lisa did talk about polyps, but I think that the note mentioned that of course it's even really important to not just track specifically colorectal cancer diagnoses, but also family members that might have polyps, that known as polyps, that might have actually have them removed or prevented. But that even for families that this has a huge impact. I don't know, Lisa if you want to talk a little bit about family history of polyps, and not just specifically cancer, but other types of polyp conditions, or revisit that quickly.
So absolutely, the more information you can know about your family members, the better, and including questions about polyps. And again, those pathology reports can be invaluable in terms of knowing the types and number of polyps, because that can certainly give a clue about whether or not there might be an inherited component linking the polyps found in a family to possible colon cancers in the family.
Okay, wonderful. So at this time, what we wanted to do was just take a little bit of a moment to have Michael, we're going to try to relaunch the polls now that we have people that are engaged and more of a full house. So what I want to do is just take this time, specifically though before Lisa and Lisa are leaving us, to thank you for your time, your expertise, the questions. We'd love if you could all stay on for the poll quickly. And also thank you, Michael Sola and then Kevin McAbee, who part of our team who are with us today. So thank you so much, and Michael, I'll turn it over to you for the initiation of the polls. And I know that our polling is in process right now, so we're asking some specific questions about family history, people's ability to collect family history, what you know, and what you've been able to capture, and plans for the future. Okay, and it looks like the polling is still in process. Okay, and our polling results are shown. So very good. Thank you very, very much. And just a quick reminder, everyone, that we will be closing closing today's session now. If you have any follow-up questions in the poll that we will be, or excuse me, the survey that we'll be sending to all of you about today's satisfaction with webinar, any questions, you can pose those questions at this time. Again, we do thank our sponsors. We do thank Lisa and Lisa and the University of Colorado team for joining us today. And just a reminder to please visit the Fight Colorectal Cancer website for a number of resources. And Kevy and myself, Kevy McAbee, who's just recently joined our team, will be following up with some resources about specific genetic tools and instruments that you might utilize and put into play given the information that was discussed today by our two fabulous presenters. So thank you all so much for your time, attention, and we'll be in touch with additional information about upcoming webinars. Thank you and have a wonderful day.